Cerebral or intracranial aneurysm. Introduction. A brain aneurysm, also known as a subarachnoid haemorrhage, SH, is a weak spot in the wall of a blood vessel inside the brain. Aneurysms are usually found at the base of the brain just inside the skull, in an area called the subarachnoid space. Aneurysms range in size, from small about 1st August inch to nearly 1 inch. Aneurysms larger than 1 inch are called giant aneurysms, pose a particularly high risk and are difficult to treat. A cerebral aneurysm more frequently occurs in an artery located in the front part of the brain that supplies oxygen-rich blood to the brain tissue. Arteries anywhere in the brain can develop aneurysms. Definition. A cerebral aneurysm, also called an intracranial aneurysm or brain aneurysm, is a bulging, weakened area in the wall of an artery in the brain, resulting in an abnormal widening, ballooning, or bleb. Because there is a weakened spot in the aneurysm wall, there is a risk for rupture, bursting, of the aneurysm. A cerebral or intracranial aneurysm is an abnormal focal dilation of an artery in the brain that results from a weakening of the inner muscular layer, the intima, of a blood vessel wall. The vessel develops a blister-like dilation that can become thin and rupture without warning. The resultant bleeding into the space around the brain is called a subarachnoid haemorrhage, SH. This kind of hemorrhage can lead to a stroke, coma and/or death. Classification. Cerebral aneurysms are classified both by size and shape. Based on size. Small aneurysms have a diameter of less than 15 mm. Larger aneurysms include those classified as large, 15 to 25 mm. Giant, 25 to 50 mm, and supergiant, over 50 mm. Based on shape. Succular aneurysms. Succular aneurysms, also known as berry aneurysms, appear as a round outpouching and are the most common form of cerebral aneurysm. Fusiform aneurysms. Fusiform dolichoectatic aneurysms represent a widening of a segment of an artery around the entire blood vessel, rather than just arising from a side of an artery's wall. They can rupture but usually do not. Microaneurysms. Microaneurysms, also known as Charcot-Bouchard aneurysms, typically occur in small blood vessels, less than 300 micrometer diameter, most often the lenticulostriate vessels of the basal ganglia, and are associated with chronic hypertension. Charcot-Bouchard aneurysms are a common cause of intracranial hemorrhage. Etiology.
A cerebral aneurysm occurs when a weakened section of a blood vessel in the brain bulges or balloons outward. The exact cause of aneurysm formation is not always clear, but several factors contribute to its development. These can be classified into congenital, genetic, factors, acquired conditions, and lifestyle-related causes. 1. Congenital, genetic, causes. Some individuals have a genetic predisposition that makes them more likely to develop aneurysms due to inherited defects in blood vessel walls. Connective tissue disorders. Ehlers-Danlos syndrome, vascular type. Marfan syndrome. Louis-Dietz syndrome. These conditions cause weakened blood vessel walls, increasing the risk of aneurysm formation. Polycystic kidney disease, PKD. Autosomal dominant polycystic kidney disease, ADPKD, is linked to a higher risk of intracranial aneurysms. Approximately 5 to 10% of people with PKD develop cerebral aneurysms. Arteriovenous malformations, AVMs. Abnormal connections between arteries and veins can increase pressure and weaken blood vessels, leading to aneurysm formation. Family history, genetic predisposition. Individuals with a first-degree relative, parent, sibling, with an aneurysm have a higher risk of developing one. 2. Acquired causes, medical conditions. Certain medical conditions can contribute to aneurysm formation by weakening blood vessels over time. Hypertension, high blood pressure, major risk factor. Chronic high blood pressure weakens blood vessel walls, making them more prone to bulging and rupture. Atherosclerosis, hardening of arteries. Plaque buildup inside arteries damages the vessel walls and increases the risk of aneurysm formation. Head trauma or brain injury. Severe trauma to the brain can lead to the formation of dissecting aneurysms, where the layers of the artery wall separate. Infections, mycotic aneurysms. Infections such as bacterial endocarditis can cause inflammation in blood vessels, leading to aneurysm formation. Autoimmune diseases, vasculitis-related aneurysms. Diseases such as systemic lupus erythematosus, SLE, and giant cell arteritis can cause inflammation and weaken blood vessels. Coarctation of the aorta. A congenital heart defect where the aorta is narrowed, increasing pressure on blood vessels and increasing aneurysm risk. 3 lifestyle-related causes. Certain lifestyle factors increase the likelihood of developing or rupturing a cerebral aneurysm. Smoking, tobacco use, strongest modifiable risk factor. Smoking weakens blood vessel walls and promotes aneurysm growth. Smokers have a 2 to 7 times higher risk of developing cerebral aneurysms than non-smokers. Alcohol abuse. Excessive alcohol consumption raises blood pressure and increases the risk of aneurysm rupture. Recreational drug use, cocaine and methamphetamine. These drugs cause sudden spikes in blood pressure, which can lead to ruptured aneurysms. Severe emotional or physical stress. Intense stress increases blood pressure and can trigger aneurysm rupture. Obesity and poor diet. Obesity is linked to high blood pressure and atherosclerosis, which can contribute to aneurysm development. 4 age and gender-related causes. Age, aneurysms are more common in individuals over 40 years old due to natural weakening of arteries. Gender, women have a higher risk than men, especially postmenopausal women due to a drop in estrogen levels, which affects blood vessel elasticity.
Sign and symptoms.
1. Symptoms of an unruptured cerebral aneurysm. Small, unruptured aneurysms often do not cause symptoms. However, larger aneurysms, greater than or equal to 10 mm, or those pressing on nearby nerves and brain structures may cause. A. Neurological symptoms. Headache, chronic or localized pain. Blurred or double vision, if pressing on the optic nerve. Drooping eyelid, ptosis. Dilated pupil or unequal pupils. Facial numbness, tingling, or weakness. Difficulty speaking or slurred speech. Loss of balance or coordination. B. Behavioral or cognitive changes. Memory problems. Difficulty concentrating. Mood changes, irritability, personality changes. 2. Symptoms of a ruptured cerebral aneurysm, subarachnoid haemorrhage, SAH. When an aneurysm ruptures, it causes a sudden and life-threatening brain bleed, known as subarachnoid haemorrhage, SAH. This requires immediate emergency medical attention. A. Classic symptoms, thunderclap headache. Sudden, severe headache, worst headache of my life. Headache starts suddenly and peaks within seconds. Often localized at the back of the head, occipital region. B. Neurological symptoms. Loss of consciousness or fainting. Seizures. Severe confusion, disorientation. Stiff neck and neck pain, due to meningeal irritation. Blurred or double vision. Difficulty speaking or understanding speech. Weakness or paralysis in one side of the body, hemiparesis. C. Systemic symptoms. Nausea and vomiting. Sensitivity to light, photophobia. Sudden dizziness or loss of balance. Rapid heart rate, tachycardia. Respiratory distress, in severe cases. 3. Symptoms of a leaking aneurysm, sentinel bleed. Some aneurysms may leak a small amount of blood before fully rupturing. This is called a sentinel hemorrhage and can be a warning sign of an impending rupture. Symptoms of a leaking aneurysm. Sudden, intense headache that resolves on its own. Neck pain or stiffness. Mild confusion or dizziness. Brief vision disturbances.
Diagnosis.
History taking. A thorough medical history helps identify risk factors and symptoms associated with a cerebral aneurysm. Chief complaints. Have you experienced a sudden, severe headache, worst headache of my life? Do you have vision problems, facial numbness, or dizziness? Any seizures, confusion, or difficulty speaking? Past medical history. Hypertension, atherosclerosis, polycystic kidney disease, PKD, or connective tissue disorders. Any previous stroke, transient ischemic attack, TIA, or head trauma. Family history. Any family members diagnosed with aneurysms or strokes. Lifestyle habits. Smoking, alcohol consumption, or drug use, cocaine, methamphetamine. 2. Physical examination. A neurological examination is performed to detect signs of aneurysm-related brain dysfunction. Neurological examination. Level of consciousness, Glasgow Coma Scale, GCS. Cranial nerve abnormalities. Dilated pupil, drooping eyelid, ptosis, or double vision, diplopia, rightward arrow possible cranial nerve 3 palsy. Facial numbness or weakness rightward arrow trigeminal nerve involvement. Motor and sensory deficits, weakness or paralysis, hemiparesis. Reflex abnormalities, hyperreflexia or Babinski sign. Neck stiffness, if subarachnoid hemorrhage has occurred. 3. Blood tests. Test. Purpose. Complete blood count, CBC. Checks for infections, high WBC, or anemia, low RBC. Electrolytes and kidney function, BUN, creatinine, Na+, K+. Important before imaging tests with contrast. Coagulation profile, PT, INR, APTT. Assesses bleeding risk before interventions. Lipid profile. Evaluates atherosclerosis risk. Blood glucose and HbA1c. Screens for diabetes, a risk factor. For advanced diagnostic tests, imaging and cerebrospinal fluid analysis. Imaging is the gold standard for detecting cerebral aneurysms. A. Imaging tests. Computed tomography, CT, scan, non-contrast CT brain. First line test for ruptured aneurysm. Detects subarachnoid hemorrhage, SAH, as hyperdense blood in brain spaces. Cannot reliably detect small, unruptured aneurysms. Computed tomography angiography, CTA. High-resolution imaging of cerebral arteries. Uses contrast dye to highlight blood vessels. Detects aneurysm size, shape, and location. Magnetic resonance angiography, MRA. Non-invasive, best for unruptured aneurysms. Uses magnetic fields to create detailed images of brain vessels. Preferred for patients with renal impairment, avoids contrast dye. Cerebral angiography, digital subtraction angiography, DSA, gold standard. Most accurate test for detecting aneurysms. Invasive procedure using catheter and contrast dye. Provides detailed vessel images, detecting even small aneurysms, LOVE, MM. Used before surgical planning or coiling procedures. B. Lumbar puncture, CSF analysis. Performed if subarachnoid hemorrhage is suspected but CT scan is inconclusive. Findings in CSF, cerebrospinal fluid. Xanthochromia, yellow CSF, rightward arrow suggests previous hemorrhage. Increased RBC count rightward arrow confirms bleeding. Medical management. Medical management is primarily aimed at preventing rupture, managing symptoms, and controlling risk factors. A. Management of unruptured cerebral aneurysms. Unruptured aneurysms may be managed conservatively in cases where the risk of rupture is low. Risk factor modification. Blood pressure control. Hypertension is a significant risk factor for aneurysm rupture. Target BP is typically 130/80 mmHg. Smoking cessation. Smoking increases the risk of aneurysm growth and rupture. Cholesterol and diabetes management, to prevent atherosclerosis, which can exacerbate aneurysm formation. Avoiding excessive alcohol and stimulant use, example cocaine. Monitoring and surveillance. Small aneurysms, 5 mm, with a low risk of rupture may be monitored with periodic imaging, MRI/MRA or CTA, every 6 to 12 months. Symptomatic treatment. Headache management, acetaminophen or NSAIDs, if no contraindications. Seizure prophylaxis, generally, not required unless the patient has experienced a seizure. B. Management of ruptured cerebral aneurysms, subarachnoid haemorrhage. A ruptured aneurysm leads to a subarachnoid haemorrhage, SAH, which is a life-threatening emergency requiring intensive medical and pharmacological management. Blood pressure control. Goal: maintain SBP 140 mmHg to reduce the risk of rebleeding. Preferred agents: labetalol, 4. Nicardipine, 4. Clevidipine, 4. Avoid hypotension, as it may worsen cerebral perfusion. Pain management. Acetaminophen, preferred, to avoid platelet dysfunction. Morphine or opioids can be used cautiously if severe pain is present. Seizure prophylaxis, controversial. Routine use is not recommended, but levetiracetam or phenytoin may be used in high-risk patients, example large hematoma, cortical involvement, seizures at presentation. Management of vasospasm, delayed cerebral ischemia. Vasospasm is a major cause of morbidity and mortality following SAH, typically occurring 4 to 14 days after rupture. Nimodipine, 60 mg orally every 4 hours for 21 days, is the only FDA-approved medication for vasospasm prevention. Triple H therapy, hypervolemia, hypertension, hemodilution, is sometimes used in refractory cases. Intracranial pressure, ICP, management. Elevate head of bed to 30 degrees. Hyperosmolar therapy. Mannitol, 0.25 to 1 g/kg for acute ICP spikes. Hypertonic saline, 3% or 23.4% NaCl4, for refractory cases. CSF drainage via external ventricular drain, EVD, if hydrocephalus is present. Prevention of rebleeding. Early aneurysm repair, endovascular coiling or surgical clipping, is critical. Antifibrinolytics, example tranexamic acid or aminocaproic acid, may be used short-term, before definitive intervention, to reduce rebleeding risk. DVT prophylaxis. Intermittent pneumatic compression devices. Low molecular weight heparin, LMWH, is initiated after securing the aneurysm. Pharmacological management. Drug class. Indication. Examples: antihypertensives. BP control, to prevent rupture/rebleeding. Labetalol, nicardipine, clevidipine. Calcium channel blocker. Vasospasm prevention. Nimodipine. Osmotic diuretics. Reduce ICP. Mannitol, hypertonic saline. Pain relievers. Headache control. Acetaminophen, morphine. Seizure prophylaxis. If indicated. Levetiracetam, phenytoin. Antifibrinolytics. Prevent rebleeding before intervention. Tranexamic acid. DVT prophylaxis. Prevent thromboembolism. LMWH, compression devices. Surgical interventions.
Surgical clipping. Aneurysms can be treated by clipping the base of the aneurysm with a specially designed clip. Whilst this is typically carried out by craniotomy, a new endoscopic endonasal approach is being trialed. Surgical clipping was introduced by Walter Dandy of the Johns Hopkins Hospital in 1937. After clipping, a catheter angiogram or CTA can be performed to confirm complete clipping. Endovascular coiling. Endovascular coiling refers to the insertion of platinum coils into the aneurysm. A catheter is inserted into a blood vessel, typically the femoral artery, and passed through blood vessels into the cerebral circulation and the aneurysm. Coils are pushed into the aneurysm, or released into the bloodstream ahead of the aneurysm. Upon depositing within the aneurysm, the coils expand and initiate a thrombotic reaction within the aneurysm. If successful, this prevents further bleeding from the aneurysm. In the case of broad-based aneurysms, a stent may be passed first into the parent artery to serve as a scaffold for the coils. Cerebral bypass surgery. Cerebral bypass surgery was developed in the 1960s in Switzerland by Ghazi Yassergil, MD. When a patient has an aneurysm involving a blood vessel or a tumor at the base of the skull wrapping around a blood vessel, surgeons eliminate the problem vessel by replacing it with an artery from another part of the body. Flow diverter surgery. This option is for larger brain aneurysms in which neither clipping nor coiling would work. In this procedure, the doctor inserts a stent, usually made of metal mesh, inside the artery. It becomes a wall inside the vessel to divert blood away from the aneurysm. Nursing management. 1. Nursing assessment. A thorough assessment is essential for early identification and management. 2. Nursing interventions. A pre-rupture, unruptured aneurysm, nursing care. For patients with an unruptured aneurysm, the goal is to prevent rupture and monitor for worsening symptoms. Maintain strict blood pressure control. Administer prescribed antihypertensives, e.g., beta blockers, calcium channel blockers. Encourage low-sodium diet, relaxation techniques. Monitor BP regularly and report significant changes. Prevent increased intracranial pressure, ICP. Avoid activities that increase ICP, such as coughing, sneezing, straining, Valsalva maneuver, heavy lifting. Elevate the head of the bed, hob, to 30 degrees to improve venous drainage. Minimize stress and anxiety through calm reassurance. Monitor for neurological deterioration. Assess pupillary response, motor function, and speech. Report any new symptoms, such as weakness, vision changes, or altered mental status. Educate the patient and family. Explain the importance of avoiding smoking, alcohol, and stimulants. Advise on the need for regular follow-up imaging, MRI/MRA. B. Post-rupture, subarachnoid haemorrhage, nursing care. A ruptured cerebral aneurysm is a neurological emergency requiring ICU-level care. Maintain airway and oxygenation. Monitor for respiratory distress, prepare for intubation if necessary. Administer oxygen therapy if SPO, 94%. Strict blood pressure control. Administer 4 antihypertensives, labetalol, nicardipine, as prescribed. Maintain SBP, 140 mmHg to reduce rebleeding risk. Prevent vasospasm, delayed cerebral ischemia. Administer nimodipine, 60 mg every 4 hours for 21 days, as prescribed. Monitor for neurological changes, such as worsening weakness or confusion. Control increased ICP. Maintain hob at 30 degrees. Administer osmotic diuretics, mannitol, or hypertonic saline if ordered. Minimize external stimulation, reduce noise, dim lights. Pain and seizure management. Administer acetaminophen for headache. Use levetiracetam or phenytoin if seizures occur. Monitor for signs of rebleeding. Sudden worsening headache, vomiting, loss of consciousness may indicate rebleeding. Prepare for emergency intervention if needed. DVT prophylaxis. Use compression devices to prevent deep vein thrombosis. Administer low molecular weight heparin, LMWH, as per protocol. See post-surgical, after clipping or coiling, nursing care. Patients who undergo surgical clipping or endovascular culling require post-op monitoring. Monitor for surgical complications. Watch for signs of infection, fever, wound drainage. Monitor for cerebral edema and hydrocephalus. Assess for neurological recovery. Regularly check motor strength, speech, and consciousness level. Report any neurological deterioration immediately. Monitor for seizures and vasospasm. Continue nimodipine to prevent vasospasm. Observe for weakness, confusion, or new stroke-like symptoms. Educate on lifestyle modifications. Encourage smoking cessation, BP control, and follow-up imaging. Advise on gradual return to normal activities. 3. Nursing diagnosis. Nursing diagnosis. Rationale. Nursing interventions. Risk for ineffective cerebral tissue perfusion. Due to aneurysm rupture and risk of vasospasm. Monitor GCS, BP, administer nimodipine, maintain ICP precautions. Risk for injury. Due to altered level of consciousness, seizures. Seizure precautions, bed in lowest position, padded side rails. Acute pain. Due to meningeal irritation from SH. Administer pain medications, maintain a quiet environment. Risk for aspiration. Due to decreased LOC or vomiting. Elevate Hob, suction PRN, monitor swallowing ability. Anxiety fear. Due to uncertain prognosis. Provide emotional support, educate patient and family. For patient and family education. Signs of worsening condition, severe headache, visual changes, confusion. Medication adherence, importance of BP control and nimodipine therapy. Follow-up care, regular MRI/MRA monitoring for unruptured aneurysms. Activity modification, avoid heavy lifting, straining, and high-stress situations. Complications. A ruptured brain aneurysm can be life-threatening and lead to cerebral vasospasm, reduced blood flow to the brain. Hydrocephalus, too much spinal fluid in the brain. Coma. Permanent brain damage. It bleeding again. Hyponatremia, low sodium in blood. Preventions. White heavy checkmark control BP, quit smoking, and avoid alcohol and drug use. White heavy checkmark adopts a heart-healthy diet and exercise regularly. White heavy checkmark screen high-risk individuals and monitor known aneurysms. White heavy checkmark avoid activities and medications that increase rupture risk. White heavy checkmark manage stress and underlying health conditions.